So it's really a pleasure to be able to join you today. I'd like to congratulate GATA and the Canadian Loeys-Dietz Syndrome Foundation, the Marfan Foundation, all participants and sponsors who've made this great meeting possible. So today I think this talk will change gears a little bit. It's not going to focus on the identification of genes, but rather the work downstream of that to try to elucidate the mechanism by which a DNA change ultimately culminates in a medical problem. Along the way, what we hope to do is to identify points of vulnerability in the pathogenic sequence for these conditions so we could hope to develop new treatment strategies. You know, our goal for a long time has been to try to understand this phenotype, aortic root aneurysm, a very common contributor to morbidity and mortality in industrialized countries. We made the very strategic decision a long time ago to initially focus on rare Mendelian presentations of aortic aneurysm because of their experimental tractability, with the hope that footholds, mechanistic footholds that were developed might prove relevant to more common but complex presentations of aneurysm. So I don't have to describe Marfan syndrome to this audience or highlight the important role of fibrillin-1 mutations in this disorder. Early on, it was recognized that microfibrils that are composed of fibrillin-1 aggregate to form complex extracellular structures called microfibrils, and that microfibrils cluster around the maturing ends of an elastic fiber during embryonic growth. This simple spatial and temporal relationship led to the rather firm belief that you need a lattice of microfibrils to make an elastic fiber during embryonic development. And if you think about it, this really boded poorly for the development of treatments. It suggested that children with Marfan syndrome are born with inadequate elastic fibers and that they therefore have an obligate structural predisposition for their tissues to fail later in life, that there's nothing you could do after birth. But it was realized that this weak tissues model did a rather poor job at reconciling certain aspects of the phenotype. For example, why would weak tissues cause overgrowth of the bones, or the craniofacial features that are common in Marfan syndrome, or the low muscle mass and low fat stores that are so characteristic of this condition? Each of these manifestations was more indicative of altered cellular performance. So to make a long story short, we and others developed evidence that microfibrils composed of fibrillin-1 serve a second important regulatory function in that they sequester the large inactive complex of a growth factor called TGF-beta and suppress TGF-beta release or activation. This direct biochemical interaction between the large latent complex of TGF-beta and microfibrils was later confirmed by Lynn Sakai and other investigators. There was also the observation that in the context of inadequate microfibrils, as we see in Marfan syndrome, there was excessive activation of TGF-beta. And on that basis, promiscuous interaction of TGF-beta with its cell surface receptor that could then initiate an intracellular signaling cascade that included phosphorylation of the SMAD signaling molecules that then translocate to the nucleus and drive TGF-beta DNA expression responses. Perhaps most importantly, multiple groups were able to show that this high TGF-beta signaling that's seen in association with Marfan syndrome has phenotypic consequences, including developmental emphysema, progressive aortic root enlargement, mitral valve thickening and dysfunction, and skeletal muscle myopathy, because each of these manifestations could be attenuated or even prevented by treatment of Marfan mice with a variety of interventions, including specific TGF-beta blocking antibodies. So around this time, this is now back in 2005, we had the strong incentive to try to transition some of these mechanistic foundations to treatment strategies. And we became interested in a class of medications, angiotensin receptor blockers, with one typical one being losartan, that had shown the ability to attenuate TGF-beta activity in rodent models of chronic kidney disease. Typically, angiotensin II signaling through its type 1 receptor called AT1 can drive production of TGF-beta ligands, receptor complexes, and activators of TGF-beta such as thrombospondin 1. In contrast, signaling through its type 2 receptor called AT2 is thought to block many of these AT1-mediated events. So the concept was that selective blockade of the AT1 cascade with drugs such as losartan would be beneficial by suppressing expression of TGF-beta effectors and perhaps also by shunting signaling through the protective AT2 pathway, a concept that we went on to demonstrate, but I won't have time to talk about today. Now back in 2006, we performed a trial of losartan in mouse models of Marfan syndrome. Here we compared the performance of losartan to that of the beta-adrenergic receptor blocker propranolol that lowers blood pressure but does not address TGF-beta. We found that propranolol-treated Marfan mice showed a significant but relative reduction in aortic root growth rate, but did not show any improvement in aortic wall architecture. There's still this dramatically thickened aortic wall, elastic fiber fragmentation, and ongoing high TGF-beta signaling as shown by nuclear accumulation of phosphorylated SMAD2. In contrast, no observer could distinguish losartan-treated Marfan mice from their normal or wild-type counterparts by any functional or histologic parameter, including complete normalization of aortic root growth rate, preservation of aortic wall architecture, and clear suppression of TGF-beta signaling as monitored by multiple variables. So we went on to try angiotensin receptor blockers in a subset of children with the most severe and rapidly progressive presentation of Marfan syndrome. As a group, these children show unrelenting growth of the aortic root despite maximal intervention with beta blockers and/or ACE inhibitors, reaching surgical endpoints or death in early childhood. We were thrilled to observe that children in this group who received losartan added on top of their standard regimen were able to achieve a plateau in aortic root growth rate. And this treatment was tried in about 20 children, and on average we saw about a 10-fold reduction in aortic root growth rate on losartan compared to their performance on prior medical therapies. Now, since then, there have been other clinical trial experiences. First, in Taiwan, Chu and colleagues, using an experimental design that was identical to ours, observed about a 9-fold reduction in aortic root growth rate once losartan was added. Pease and colleagues in Austria observed a significant decline in normalized aortic root growth rate and a decline in aortic root Z-score. And Groening and colleagues in the Netherlands, in a trial in adults with Marfan syndrome, saw a significant decline upon addition of losartan to standard therapy. Interestingly, even in patients that had prior aortic root surgery, they saw that addition of losartan improved the performance of the remainder of the aorta in the post-surgical period. Now, I'm sure many or most of you are aware of a large trial in children with moderately severe Marfan syndrome that was performed by the Pediatric Heart Network. Here, there was a slow rate of aortic root growth in both arms of the trial. Children were randomized to receive either beta blockers or losartan. In both groups, there was a significant decline in aortic root Z-score over time that was sustained during the three-year follow-up period, but there was no significant difference between the groups. Now, the details of this trial are interesting to consider. Atenolol was used at very high dosing, a mean dose of about 3 milligrams per kilo per day and up to 4 milligrams per kilo per day. So about 1.5 to 2 times the FDA-approved level of use for the treatment of hypertension, whereas losartan was capped and the mean dose was slightly below the FDA-approved antihypertensive dose. I think it's interesting to note that in both arms of this trial, the rate of growth was significantly less than that previously described for untreated pediatric patients with Marfan syndrome or those treated with more typical atenolol dosing. So I think the concept that was making itself clear to us is that dose matters. We've now returned to the mouse model and done a full dose titration. If we gave these mice a high dose, what we call medium dose propranolol, but 20 milligrams per kilo, we did not yet see a significant decline in aortic root growth rate. If you went to ultra high dosing, up to 40 milligrams per kilo, you can see that you now have a significant but relative reduction in aortic growth rate. At low dose losartan, here 5 milligrams per kilo, you can see that there is significant improvement and even a better improvement than was seen in medium dose propranolol. But at each subsequent increase in dosing, you see a further decline in aortic growth rate, even after you're no longer having any further impact on hemodynamics in these mice. So in keeping with this concept that dose matters, I was intrigued to learn the results of a trial that was reported at the recent European cardiovascular meetings, the so-called AIM study. It's a collaborative study of 22 centers in the United Kingdom. Here, patients were randomized to receive irbesartan or placebo on top of their baseline therapy, which largely was beta blockers. In very young children, the dose of irbesartan that was used was extremely high, 150 milligrams. In older children or adults, they received the full adult dosing of 300 milligrams. What was observed is a significant decline in aortic root growth rate in the irbesartan group and a more rapid decline in aortic root Z-score in the patients treated with irbesartan. There was greater benefit in young children and those with bigger aortas, no signal for interaction between irbesartan and beta blockers, and tolerance was excellent even in young children. So the bottom line is I think that both treatment options have merit, angiotensin receptor blockers and beta blockers, but there's more to do to learn how to optimize these strategies and hopefully to find even better therapeutic options for these conditions. Now around 2005, my good friend and colleague Bart Loeys and I recognized and described an aortic aneurysm syndrome that had many features in common with Marfan syndrome, including scoliosis, pectus, long fingers, and aortic root aneurysm, but also the potential of many unique features, including hypertelorism or widely spaced eyes, a cleft palate or a bifid uvula, fusion of the skull, club foot deformity, and certain forms of congenital heart disease. But most importantly, this strong tendency for aneurysms, not just at the aortic root, but all throughout the arterial circulation, including the head and the branch vessels of the aorta, and also leg vessels. And in these children that we were seeing in our clinic, it was very clear that they were not behaving the rules. We were seeing rupture or dissection at young ages, as young as 6 months of age, and at small dimensions with frequent dissection at measurements at or around 40 millimeters in adults. Now, many groups throughout the world have participated in an intense effort to identify genes responsible for syndromic presentations of aneurysm. And we and others have now shown that mutations in genes along the entire TGF-beta signaling cascade can cause Loeys-Dietz-like syndromes, including both TGF-beta 2 or TGF-beta 3, either component of the TGF-beta receptor, and the two intracellular signaling molecules SMAD2 or SMAD3. We were also able to show that mutations in a gene called SCI cause a very closely related condition called Shprintzen-Goldberg syndrome. These individuals have virtually all of the manifestations of Loeys-Dietz syndrome with the added feature of highly penetrant developmental delay. SCI is a very interesting molecule that works in the nucleus to prevent TGF-beta-driven gene responses. So in Shprintzen-Goldberg syndrome, we see loss of function of a negative regulator of TGF-beta signaling, and a condition that looks very strikingly like Loeys-Dietz syndrome. Indeed, if you tabulate the various physical manifestations in these different conditions, you can see clear themes emerging. You can see that the Marfan-like features are common to Shprintzen-Goldberg syndrome and many different flavors of Loeys-Dietz syndrome. You can see that there is uniquely developmental delay in the nuclear suppressor of TGF-beta signaling, but not in other presentations, but that there are also a wide variety of manifestations that are seen in the full spectrum of Loeys-Dietz syndrome, albeit at variable severity. Now, to try to understand Loeys-Dietz syndrome, we went on to make mouse models by introducing mutations that we had initially observed in patients with this condition. We saw the very clear signature for excessive TGF-beta activity as shown by phosphorylation of SMAD2 in the root of the Loeys-Dietz mouse model, but not in other aortic segments such as the more distal ascending aorta or the descending aorta. As we had seen in the Marfan mouse models, we saw that losartan was dramatically protective, in fact, full normalization of aortic root growth rate. And in this context, beta blockers, even at very high dosing, did not have a comparable performance. Use of angiotensin receptor blockers such as losartan also had striking beneficial effects on the architecture of the aortic wall, for example, preventing elastic fiber fragmentation. We've now gone on to make mouse models of Shprintzen-Goldberg syndrome by introducing a very severe mutation that we had seen in a patient with this condition. You can see that there is very dramatic aortic root enlargement in this mouse model of Shprintzen-Goldberg syndrome. They also have skeletal and craniofacial manifestations of the disorder. As you might expect, all the TGF-beta target genes that we looked at are greatly increased in the Shprintzen-Goldberg syndrome model. And quite remarkably, losartan is dramatically protective in this mouse model, again, both preventing progressive aortic root growth and breakdown within the aortic wall. So taken together, these data suggest a broadly relevant mechanism, TGF-beta, and treatment strategy, AT1 blockade, in syndromic presentations of thoracic aortic aneurysm. But in keeping with our goal to see if there is a way to do better, if we could find the Achilles heel in these conditions, we've gone on to consider other aspects of the signaling cascade. So what I've talked to you about so far is the so-called canonical or SMAD-dependent TGF-beta signaling arm. But it's also known that stimulated TGF-beta receptors can activate so-called non-canonical pathways, prominently including the mitogen-activated protein kinases ERK, JNK, and P38. So when we looked at these non-canonical cascades, we were quite startled to see the extent of increased activation of ERK within the aortic wall of our Marfan mouse model compared to their normal or wild-type littermates. we were able to show that this high ERK activation in the Marfan aortic wall was at least in part TGF-beta dependent. If you gave a TGF-beta blocking antibody, the activated ERK levels went back down to normal. We didn't know if ERK was a marker of disease or actually a driver of disease. So to address this, we gained access to an orally bioavailable, highly selective and potent ERK blocking drug called RDEA-119. And we're able to show that this was every bit as effective as angiotensin receptor blockers in suppressing abnormal aortic growth in the Marfan mouse model. As predicted, this highly specific drug did suppress ERK activation in Marfan mice without having any effect on any of the other signaling cascades under consideration. So we had a new landmark. ERK is bad. And our question was, could we use this information to address underserved or particularly vulnerable patient groups? One such group is women with Marfan syndrome who choose to become pregnant. As we've talked about, there is a high risk of aortic dissection in patients with Marfan syndrome and large aortic roots. This risk, as was mentioned by Jasmine earlier today, has historically been attributed to hemodynamic stress, but it seemed odd that the vast majority of dissections that we've observed in women with Marfan syndrome in association with pregnancy occur within the days to weeks after delivery, not leading up to delivery. And we were not seeing that this risk was significantly altered by cesarean section or antihypertensive agents. So we asked, what is initiating toward the end of pregnancy, maintained after delivery, and that might synergize with some of these signaling events that we had previously defined for aneurysm and dissection? And the hypothesis that we came up with is the hormone oxytocin, which is needed to initiate uterine contraction, but also milk letdown. Its release peaks at the end of pregnancy, but is also sustained during breastfeeding. Importantly, the receptor for oxytocin is upregulated in the aorta in response to pregnancy. And we were really intrigued when we learned that the mechanism by which oxytocin stimulates peripheral tissues is through ERK activation. So we used a mouse model that was developed by our colleague Francesco Ramirez and colleagues at Mount Sinai. And this particular mouse model of Marfan syndrome shows an extreme risk of aortic dissection in the 3 weeks or so following delivery. There's virtually no prenatal dissection in this mouse model, but close to 100% death due to aortic dissection in the postpartum period. This is very different from female Marfan mice that were never pregnant, shown in black, and male Marfan mice shown in red. So we asked a very simple question. What would happen if you allowed these mice to become pregnant, allowed them to deliver, but simply took the pups away right after birth to prevent lactation-induced oxytocin release? And the answer was that this simple manipulation transitioned survival from near 0% all the way up to about 80% just by removing the pups. We then asked, well, what would happen if you used a specific oxytocin receptor blocker toward the end of pregnancy and maintained its use after delivery? And the answer was that that led essentially to 100% survival in this Marfan mouse model. Interestingly, the outcome perfectly paralleled the level of ERK activation in the aortic wall, which is high in Marfan syndrome, dramatically increased in Marfan mice that are lactating, brought back down to baseline by removing the pups or treatment with the oxytocin receptor antagonist. On this basis, we tried a selective ERK inhibitor that is FDA approved for use in certain types of cancer, including melanoma, called trametinib. And we found that this had a dramatic ability to prevent pregnancy-associated aortic dissection in Marfan mice. So I'm not sure, in fact, I'm pretty sure that an ERK inhibitor is not going to be something that is embraced for the use during pregnancy or immediately after delivery, but I think that this is pointing to a number of therapeutic targets that require future exploration. Importantly, oxytocin receptor blockers are approved for use in preterm labor in Europe, and there are a number of new oxytocin receptor blockers that are being developed and explored currently. Now, a few years ago, we reported a pretty dramatic finding that was related to the use of calcium channel blockers in Marfan syndrome. They had been considered second-line antihypertensive agents in Marfan patients who were unable to tolerate beta blockers, for example, those with asthma or depression. If you looked at the literature, there were reports that calcium channel blockers could reverse ERK activation, for example, in spontaneously hypertensive rats, and that other calcium channel blockers could reduce ERK activation in synergy with angiotensin receptor blockers such as olmesartan. So we were initially quite optimistic going into this trial. The trial involved the use of amlodipine, and the mice were followed by echocardiography. So here is an echocardiogram of a normal or wild-type mouse. The yellow arrowheads are showing you the aortic root. We know that we're in systole because the aortic valve is open. The red arrowheads are showing you the more distal ascending aorta. In the Marfan mouse model, you can see significant aortic root enlargement, but preservation of the size of the more distal ascending aorta. In normal mice given amlodipine, we really didn't see much. Perhaps the ascending aorta was looking slightly generous, but in virtually 100% of Marfan mice given amlodipine, we saw the hyperacute development of giant ascending aortic aneurysms. The ascending aorta literally tripled in size within about 3 to 4 weeks of starting medication, with the onset of death due to aortic tear within about 5 weeks. There is some acceleration in the growth of the aortic root in calcium channel blocker treated mice, but a much more dramatic acceleration in the distal ascending aorta, an aortic segment that's typically preserved in Marfan syndrome. We also found that this was not strictly related to the high dose of amlodipine that was being used. If you brought down the dose considerably, about threefold, you can see that there is still this striking abnormal performance of the ascending aorta. Here I'm showing you the death due to aortic dissection that we see in association with the use of calcium channel blockers, and also that this is not strictly related to amlodipine. In fact, every class of calcium channel blocker that we've tried shows this a similar detrimental effect on aortic growth. Now, contrary to prediction, we found that calcium channel blockers were accentuating the abnormal canonical and non-canonical signaling events in the Marfan mice. We found that if you gave calcium channel blockers plus ERK inhibitor at the same time, that you could largely prevent this deleterious gene by environment interaction. This associated with full normalization of survival in calcium channel blocker treated Marfan mice, and also had the expected effect of suppressing abnormal ERK activation that occurs in association with calcium channel blocker use. So really a strong signal that ERK is the dominant driver of vascular disease in this mouse model. Here I'm showing you these giant ascending aneurysms that we see in association with calcium channel blocker use, with a very dramatic fibroproliferative response within the aortic wall, including a tremendous increase in the deposition of collagen, as you might predict with high TGF-beta activity. If you give these mice calcium channel blocker plus the ERK inhibitor, the aorta doesn't simply go back to normal. It actually more resembles wild-type mice than it does Marfan mice that were treated with placebo, really suggesting that ERK is the dominant event, activation of ERK in Marfan mice. Now this presented a dilemma. We could make connections between angiotensin signaling, between TGF-beta, and between ERK by looking at the literature. But the question was, where do calcium channel blockers fit into all of this? Now, if we looked further in the literature, we found that TGF-beta and angiotensin 2 type 1 receptor signaling can increase the activation of phospholipase C, and that through a downstream IP3 PKC axis could ultimately culminate in ERK activation. CCBs have the known ability to accentuate both TGF-beta and PLC activation. And in keeping with this, we saw that in our Marfan mice that were treated with calcium channel blockers, here verapamil, we indeed see a signal for increased PLC activation. If this is the right pathway, if we're interpreting this correctly, we concluded that medications such as enzastorin that block PKC activation should be protective. And indeed, we saw that there was a significant reduction in aortic growth rate in calcium channel blocker mice treated with enzastorin. Here we asked, have we only learned something about this very artificial effect, this event that's occurring in Marfan mice treated with high doses of calcium channel blockers, or perhaps have we learned something fundamental about the disease process itself? So to answer that question, we decided to treat Marfan mice with enzastorin that had not been treated with calcium channel blockers. And here we saw, in fact, the best therapeutic response we've ever observed, with a slight but significant regression in aortic size over time, with clear evidence for suppression of PKC and ERK activation. Now, if this is true again, we predicted that the FDA-approved antihypertensive agent hydralazine would be protective, because it's known to work, at least in part, by blocking IP3-mediated PKC activation. We went on to treat Marfan mice with hydralazine and observed a dramatic reduction in aortic root growth rate in association with the predicted signaling consequences of decreased PKC and ERK activation. Now, this was important because hydralazine, unlike angiotensin receptor blockers, can safely be used during pregnancy. We returned to our pregnancy mouse model and observed that treatment with hydralazine was dramatically protective against pregnancy-associated aortic dissection. We also found, as expected from this cascade, that losartan remained dramatically protective in calcium channel blocker treated Marfan mice. So all in all, we have pretty high confidence in this pathogenic sequence. We've kind of poked and prodded it in every way we could imagine. All the interventions that we predicted would worsen aneurysm, shown in red, indeed lead to aneurysm progression, and all the interventions that we predicted would suppress aneurysm indeed had that desirable effect. Importantly, oxytocin signaled through the oxytocin receptor, which works by activating the PLC, IP3, PKC, and ERK axis. Now, you might say this is all well and good about mice with Marfan syndrome, and what about people? So to begin to try to address this, we partnered with the GenTAC Consortium, as you know, that collects clinical information on large numbers of patients with genetically induced forms of aortic aneurysm. We found that if at the time of enrollment, a patient with Marfan syndrome was receiving calcium channel blockers, that there was an odds ratio for aortic dissection during the follow-up period of about 12.5. This was also true if you considered all forms of thoracic aortic aneurysm. We also saw that the odds ratio for aortic surgery during the follow-up period was about 5.5. So at least a suggestive signal that what we're observing in mice is relevant to people with inherited forms of aortic aneurysm. Now, up until this point, everything that we were doing was very hypothesis constrained. We were making an observation and predicting what the next logical consequence was and testing that. But we wondered whether we could use a so-called unbiased strategy to find something completely new and different. Along the way, had the opportunity to care for a number of families with Marfan syndrome that showed really striking variability in clinical severity, even within an individual family. For example, in these families, people shaded as black symbols have classic severe Marfan syndrome, often with the need for surgery in late childhood or young adult life. In the same family, individuals shaded as blue have no manifestation, vascular manifestation of Marfan syndrome, including people that are now in their 50s and 60s. So we asked, is there a way that we could identify the modifier, identify the genetic strategy that's being used by nature to protect some people with Marfan syndrome, but not others, despite the fact that they have the identical underlying FBN1 mutation? So in collaboration with Bart Loeys and Julie DeBacher and Anne DePop, we initiated a modifier linkage study to try to identify the region, the genomic region that has this protective variation. And quite dramatically, all of the families were segregating protection along with markers on human chromosome 6, not where the Marfan gene is on chromosome 15, but rather a unique locus. Now, if we looked at this area, there were 32 genes in this interval, but one of them kind of jumped out at us as potentially being important. It's a gene called MAP3K4, and it encodes a protein that activates mitogen-activated protein kinases, such as ERK and P38. When we looked at Marfan patients who were mild and compared them to those who were severe in relation to the level of expression of MAP3K4, we saw that there was significantly higher expression in those that showed the severe phenotype. So we went back to our Marfan mouse model and we simply deleted one copy of the MAP3K4 gene and found that that was sufficient to normalize aortic root growth rate and also to fully normalize all of the observed cellular signaling events, including the activation of ERK and also the activation of P38. Around the same time, we recognized very dramatic mouse modification. We learned if we put our Marfan mutation in a mouse strain that's called the Black 6 strain, the aneurysms dramatically disappeared, whereas if we put the same mutation on a different mouse strain called the 129 strain, the aneurysm was greatly exaggerated. So here's an echocardiogram of a Marfan mouse on the protected Black 6 strain. And you can see this rather normal appearing aortic root in relationship to the sinotubular junction in the more distal ascending aorta. Whereas the same mutation on the severe 129 strain is leading to these giant aortic root aneurysms and earlier death due to aortic dissection. There's no difference in heart rate or blood pressure between the strains, so that wasn't the explanation. If we looked at cellular signaling events, we can see that in the severe 129 strain, all of the cascades that I've been talking about, the SMAD cascade, the ERK signaling cascade, they're all greatly accentuated compared to the protected Black 6 strain. We also learned that the severe 129 mice
remained fully responsive to either ERK inhibitors or to losartan. So it's really suggesting that what we're observing is relevant to what we had previously defined for Marfan mice. So we did an exercise. We took the severe strain and the mild strain and bred them together. And we mixed up their chromosomes and then selected for mice that either had a very severe phenotype or a very mild phenotype. And we asked, among mice that had the very mild phenotype, what part of the protected BLAK6 background did they retain? Which genes in the BLAK6 background were important to make their disease mild versus severe? And the answer was somewhat surprising and dramatic in that all of the difference in phenotype between the two strains could be explained by considering genes on two mouse chromosomes, mouse chromosome 5 and mouse chromosome 11. You can see these very dramatic peaks. This means that there's 10 to the power of 5 odds favoring that there's something real going on here as opposed to something simply by chance. Now, there's also evidence that these two genes at these two positions are talking to each other, because if you consider them both in combination, then the odds are 10 to the power of 13 that there's something true and physiologic that's occurring. Now, we looked for genes of interest in these regions, and two jumped out to us. One is called the MMP17 gene that's known to regulate ERK activity. The other is called a MAP2K6 gene, which is also known to activate mitogen-activated protein kinases like ERK and P38, and is activated by MAP3K4, the human modifier. So by considering two different species, it appears that we're identifying a pathway of modification. We went on to look at mice that were bred to each other to create a mixed mouse background. The red bar is indicating the performance of the severe pure 129 mice. You can see that there is very rapid aortic growth. The green bar is representing the performance of the pure BLAK6 strain. You can see that there's very low aortic growth. Now, in these mixed mice, we knocked out individual copies of the MAP2K6 or the MMP17 gene. So in these mixed mice, if you knocked out both copies of both genes, they behaved exactly like the protected BLAK6 animals. In these mice, if you had functional 129 copies at just these two genes, they behaved exactly like the pure 129 mice. So really strong evidence that these two genes are responsible for the modification. We can see that if you knock out MMP17 alone, you significantly reduce the level of ERK activation, completely normalize the level of SMAD activation. If you knock out both of those genes, you're back down to BLAK6 or protected levels. So how does MMP17 influence ERK activation? It turns out that this very interesting membrane-bound molecule has the ability to activate a receptor called the EGF receptor, which then signals through the PLC, IP3, PKC axis to end up culminating in ERK activation. As predicted by this model, we do see excessive activation of the EGF receptor in the severe 129 mice. We see if we knock out MMP17 and just MMP17, that is fully normalized in the mice. And finally, if we give an FDA-approved drug that blocks the EGF receptor, we can dramatically suppress aortic growth and fully normalize all of these signaling events. So a consideration of genetic modification, I think, has pointed to nature's methods of successfully protecting both people and mice with Marfan syndrome. And we think that leveraging nature's strategies, mimicking nature's methods of protection using medications now represents potentially important treatment options. So I want to end by talking about vascular Ehlers-Danlos syndrome. People in this audience are very aware of this condition, has facial, cutaneous, and vascular complications, including a risk for spontaneous dissection or rupture of the aorta or other vessels, often without prior dilatation. Importantly, in this condition, there's no particular predisposition for aortic root enlargement, unlike Marfan syndrome or Loeys-Dietz syndrome, but a frequent occurrence of aneurysms elsewhere in the arterial tree. So a very talented graduate student in the lab has now made 2 bona fide mouse models of vascular Ehlers-Danlos syndrome by knocking in a glycine substitution that either occurs early or late in the triple helical region of the molecule. What you'd predict is that an early substitution would lead to a more mild phenotype than a later substitution, and that's exactly what we observe, that in the mild model, the median survival is about 400 days, whereas in the severe model, the median survival is only 45 days. All of these mice die from aortic dissection. They all have hemothorax or hemopericardium or hemoabdomen at the time of necropsy. Now, we went on to test some existing therapies that have been proposed for vascular Ehlers-Danlos syndrome, with the most important one being the beta blocker celiprolol. This was tested in a relatively small, somewhat poorly controlled and controversial trial in Europe, but the general takeaway message was that celiprolol appeared to reduce the frequency of severe cardiovascular events. And when we gave celiprolol to our severe mouse model of vascular Ehlers-Danlos syndrome, here in red you see the performance of mice that were not treated with celiprolol. In blue you can see that celiprolol treatment led to earlier and more frequent death due to aortic dissection and rupture. This, as you can imagine, was quite surprising and not predicted. When we looked at the more mild mouse model of vascular EDS, that in this time frame of 40 days would typically show 0% incidence of death due to dissection, again, you can see that celiprolol use is definitively detrimental. When we tried losartan in this model, we did not see a signal for protection. It also didn't have any worsening effect on the disease. It just appeared to be neutral in this study. So this is clearly telling us that there's something new and different going on here. We can't just rely on what we've learned about these other conditions. Caitlin went on to do expression profiling of the aorta of vascular EDS mice and compared that to normal mice. So here we're looking at the expression of 20,000 genes. And when you look at the ones that are more highly or low or show lower expression in vascular EDS compared to control mice, the 2 themes were something called GPCR or G protein coupled receptor signaling pathways and our old friend MAP kinase signaling pathways, very prominently collapsing on the ERK signaling cascade. So there are a lot of G protein coupled receptors, including the angiotensin II type 1 receptor, also including the beta adrenergic receptor. They all collapse on signaling through the PLC, IP3, PKC, ERK axis. So again, we wanted to see whether this was in play in vascular Ehlers-Danlos syndrome. We used the FDA-approved and now orally available ERK inhibitor cobinetinib, and we could see that that significantly improved performance in these mice, reduced the rate of aortic dissection and death. We went on to look at a PKC inhibitor and saw that this led to 100% survival in the vascular EDS mice compared to untreated animals. We went on to try hydralazine, which remember works between IP3 and PKC. And here we saw something very interesting. Early on in the trial, hydralazine led to 100% survival compared to mice that were untreated, which were dying rapidly within those first 40 to 50 days. But right around the time of sexual maturity, the vascular EDS mice began to show very dramatic death due to aortic dissection. When we stratified this by gender, this is much more pronounced in the male vascular EDS mice than it is in the female mice. And this is somewhat reminiscent of what's seen in young men with vascular EDS, with a clear prior demonstration that for certain subgroups of patients with vascular EDS, puberty and the time around sexual maturity is particularly risky. We're now doing a trial of hydralazine together with an androgen inhibitor that started at around the time of puberty to ask if that is potentially a strategy that could be considered to get these mice through that difficult transition. We again saw that there is increased risk of aortic dissection in association with pregnancy in the vascular EDS mice, that if you simply remove the pups and prevent lactation, there's 100% survival. If you give these mice an ERK inhibitor, there's a very significant reduction in pregnancy-induced aortic dissection. And this is perhaps the finding that I'm most excited about. Now, it's confusing because it's different from Marfan syndrome, but in both the mild and severe vascular EDS mouse model, we find that the 129 mouse background, the one that made Marfan mice worse, actually leads to essentially complete protection from vascular disease in EDS. So as you can imagine, we're doing the interbreeding study to try to map the modifier that's responsible for protection. But this is the first evidence that I've observed that suggests that nature does have a strategy to beat this devastating condition. So as a final conclusion, a confluence of clinical observation-driven hypothesis and now unbiased inquiry has greatly informed our mechanistic understanding of these conditions and has revealed a number of promising treatment strategies, including a number that are already FDA approved and could be explored in the short term, and others that are in clinical development in partnership with pharmaceutical companies. So I'd like to end by acknowledging the extremely talented young people that I have the privilege of working with. I'd also like to acknowledge my collaborators at Johns Hopkins and at other institutions, also my funding sources, and I'd be happy to answer questions. Thank you for your attention.
Thank you so much for really a tour de force of mechanistic data and new possible therapeutic targets. We have time for maybe just one or two questions before the next session. Burning questions? No, no burning questions. Tim always has a burning question. So does Gabby. Perfect. Yeah.
Thanks, Hal. That was a wonderful talk, as usual. It's exciting to hear. Is the AIM study published, or has it just been presented?
It's been presented. There was a press release about it, so a lot of the details are publicly available.
Right. So that's really exciting. Just to go back to the Brooks study, what was the average dose of losartan that you used in that study, and what's the follow-up been of those sort of patients in the long term? And then just a quick follow-on question, really exciting, all these wonderful mechanistic sort of targets, but how far off are they from clinical trials, do you think?
Yeah, so the average dose that was used in the Brooks trial was somewhere between 1.5 and 2 milligrams per kilo per day.
We have followed many of those kids. We don't have follow-up on all of them. They are all what would have been considered in the neonatal category of Marfan syndrome, and they're all alive and doing well in their early teens now. Many of them have required aortic surgery, and quite a few of them, as you might imagine, also required mitral surgery.
Yeah.
But they did continue to show a dramatically slower rate of growth than they had declared prior to the initiation of ARB therapy.
And the trials?
And the trials, so I think that for some of these agents, the risk-benefit ratio would not favor going ahead. For example, ERK inhibitors are showing tremendous potential, but a known complication of all available ERK inhibitors is retinal detachment. So it's really not something that you'd want to use in this patient group. That's why we're particularly intrigued by these modifier studies, because it's showing us individual pathways that are driving abnormal ERK activation. There are other pathways that activate ERK, more physiologic pathways, that you could leave unperturbed by just targeting, for example, the MAP2K4, MAP3K6 pathways. So those, in fact, we're in very advanced work with a pharmaceutical company to develop selective MAP2K4, MAP3K6 inhibitors. And I think that those could be brought to trial pretty quickly.
I have a very pragmatic question.
Yes.
I help look after a family who the woman has Ehlers-Danlos type 4. She's in her 50s. Her brother died of a ruptured thoracic aortic aneurysm. Father the same. And brother last week had a spontaneous right coronary dissection that he survived. What would you suggest that I tell them in terms of clinical trials or possibilities for treatment?
So right now, it simply continues to make sense to me that something that reduces hemodynamic stress, even if it's not acting through some of these signaling cascades, simply makes sense in these disorders. I would certainly not petition for access to celiprolol based upon what we know so far. I think that use of a beta blocker, a more conventional beta blocker that does not have beta-2 receptor agonist activity, it would likely be protective. In fact, we have data along those lines. Losartan, I think, is a good drug to reduce hemodynamic stress. We don't have evidence that it's having the magical kind of protection that it does in Loeys-Dietz syndrome, but by all accounts, it's a safe medication to use in this context. Hydralazine is an interesting drug to consider. It would not be my first choice. If God had said, Hal, what drug do you hope works in vascular EDS, I would not have picked hydralazine. It's a 4 times a day drug. It has the potential complication of causing lupus-like syndrome in a small subset of individuals. But I think in certain contexts, hydralazine would be a medication to consider. So my personal style would be to use something, and I would probably offer all 3 of those options to individuals.
I may be sending you this patient.
Okay.
Fantastic. Thank you so much.